Dzień dobry, witam wszystkich Państwa bardzo serdecznie na międzynarodowej 69. edycji międzynarodowej konferencji Silesian Intermedical Congress. Jest nam bardzo miło powitać wszystkich Państwa. Cieszymy się, że zechcieli Państwo wziąć udział w niniejszym przedsięwzięciu. Pragnę zacząć od przywitania członków komisji. Witam serdecznie Panią Przewodniczącą Komisji, Panią doktor habilitowaną nauk medycznych Annę Balcerzek-Matić. Witam również Panią doktor nauk o zdrowiu Joannę Zembale-John. Witam także dwóch członków komisji, którzy są z nami obecni poprzez połączenie online. Jest to pani doktor nauk medycznych Anna Deda.
Tak, dzień dobry.
A także pan doktor nauk o zdrowiu Mateusz Grajek.
Dzień dobry.
Drodzy uczestnicy, szanowna komisjo, pozwolę sobie jeszcze tytułem przypomnienia uwypuklić nasze zasady konferencji. Czas przewidziany na Państwa wystąpienie to 7 minut, z kolei czas przewidziany na dyskusję, czyli zadawanie pytań przez jury, wynosi 3 minuty. Kolejność wystąpień jest analogiczna do kolejności, która była zaprezentowana w książce abstraktów i pozostaje ona niezmienna. Członkom jury przypominamy również o tym, iż nie mogą oceniać pracy, z którą są powiązani, czyli nad którą sprawowali pieczę. Jeżeli nie ma autora w danym momencie danej pracy, no i nie zjawi się on w swojej kolejności, to automatycznie przechodzi on na ostatnią pozycję swojego wystąpienia w dniu dzisiejszym. Jury będzie oceniało następujące elementy wartości Państwa prac. A za każdy element mogą przyznać wartość od 1 do 5 punktów. Jest to wartość naukowa, sposób prezentacji, dyskusja, wkład własny, a w przypadku, jeżeli autor, bo nie jest to obligatoryjne, jeżeli autor wygłosi swoją prezentację w języku angielskim, końcowy wynik zostaje powiększony o 20% punktów. Myślę, że możemy zacząć dzisiejszą sesję zdrowia publicznego i ochrony zdrowia.
Jeszcze tutaj szybko taka informacja do jury. W związku z tym, że jeśli jakaś osoba się nie pojawi, to prosiłabym o pominięcie miejsca i zostawienie tego miejsca, jeśli ta osoba ewentualnie pojawi się na sam koniec, żeby można było ją jeszcze ocenić, żeby kolejność prac była zgodna. Dziękuję bardzo.
Dobrze, więc zaprosimy pierwszego prelegenta, właściwie prelegentkę. Będzie to pani Emilia Rogowska z tematem Pinworm Infection Prevalence in Silesian Kindergartens in the Context of Sanitary Regulations and Prevention.
Good afternoon, ladies and gentlemen. My name is Emilia Rogowska, and I am honored to be speaking before you today on the topic of enterobiasis, specifically focusing on its occurrence in Silesian preschools. Before we begin, let me give you a brief background overview and significance of our study. And enterobiasis is a parasitic infection caused by the Enterobius vermicularis parasite. It is common worldwide infection with a higher prevalence among children, mostly in the preschool age. The transmission of the parasite is through the fecal-oral route, and it can spread easily within households and preschools, mostly due to close contact and low hygiene levels. The aim of our study was to check compliance with regulations on chosen hygiene measures in Silesian preschools facilities, as well as to trace the incidence of enterobiasis. Our study collected data through a questionnaire consisting of 26 questions. 22 of them were closed and 4 of them were open-ended. The survey was, of course, conducted electronically using online forms, as you've seen on the previous slide, and it targeted directors of preschools in the Silesian Voivodeship in Poland. Each of 1,639 facilities was sent an email with the invitation to fill out the paper, but the data was collected in the first quarter of 2023. And while the questionnaires were distributed to all units included in the survey, it has to be noted that some of them were informed and asked to participate in by a phone call. And answers provided through that questionnaire were counted in 173 of them. Of kindergartens revealed that 30%, so 52 of those facilities did report cases of enterobus vermicularis infection in past 3 months. Surprisingly, the majority of those cases, so 77 reports, came from only the parents, while a small percentage of 4% was solely reported through preschool staff. Another 20% were combined from both sources. Another topic is convenient access to wash basins, because it is essential for promoting regular and effective hand washing, a basic hygiene procedure helping with fighting a lot of bacterial and parasitic infections, of course, enterobiasis included. And in our results, out of the 173 kindergartens that participated, it was found that 6.9%, so 12 of them, did not meet the standards for wash basins, and that indicates a lack of compliance with the Ministries of Education regulations regarding the maximum number of children per one wash basin, which is no more than 15. Furthermore, this study sheds light on a need to improve hygiene practices in Silesian, mostly Silesian preschools, because shockingly, 18 of them require their children to wash hands 3 to 4 times a day, which is simply not enough because frequency recommended by World Health Organizations is at least 5 times a day. The implications of these findings are clear. Enterobiasis remains a prevalent issue among preschool children in the Silesian Voivodeship. And to effectively address this problem, it is crucial to strengthen communication channels between both parents and preschool staff, as well as promote a collaborative approach to identify and address this issue. And well, thank you for your attention, and I'll be happy to answer any of your questions you may have.
Bardzo dziękujemy za to wystąpienie. Prosimy szanowną komisję o zadawanie. Question about the schedule in the kindergarten, because not every kindergarten has the same daily schedule and the custom of naps for children. So did you take it under consideration in a questionnaire?
No, we did not question about each of the preschool schedule. We asked more about whether it's a public or private one, in whether it's how is it leaded, whether they have any significant changes to how they teach their children. But yeah, we did not ask about naps, to be exact.
Okay.
I don't have any questions for now.
Okay.
Jeszcze ktoś z członków komisji, która jest połączona online, może ktoś chciałby zadać pytanie autorce?
Mogę mieć takie techniczne pytanie, czy dałoby się ten pasek tak zminimalizować, tak, bo treści danych nie widziałyśmy.
Można to ewentualnie na górę przeniósł. Thank you very much.
Bardzo dziękujemy, wielkie brawa. Teraz zaprosimy drugą prelegentkę, będzie to Paulina Rutecka z tematem pod tytułem Vaccinological Prophylaxis of Seasonal Diseases among Medical Students, Influenza and COVID-19 Vaccination.
So good morning, ladies and gentlemen. We are very happy to have an opportunity to present our work today. And the title of our presentation is Vaccinological Prophylaxis of Seasonal Diseases Among Medical Students, Influenza and COVID-19 Vaccination. And the plan of our presentation can be shown as follows. Starting with materials and methods, a little flu never killed nobody, why medical student wants to be a threat to patients, practice make you more conscious, vaccination campaigns, discrepancy between medical faculties, availability of vaccination points, finding the positives from the COVID-19 pandemic, and what can we do? So I would like to start with some information about our research. As you can see, it was an online cross-sectional study conducted among students of Medical University of Silesia in Katowice in November 2022. And 302 students of both medical and health courses took part in the survey, and the data was submitted to statistical analysis using Statistica package. A little flu never killed nobody. So the main response, the respondents say that they did not vaccinate, was the lack of fear of the flu. To assess the validity of this argument, I presented data estimated by the World Health Organization. And I would also like to mention that this estimate did not take into account other than respiratory diseases, which can be also associated with influenza, so the number of deaths can be even larger. And when we ask why they did not vaccinate, the main responses were mentioned lack of fear of the flu, but also no recommendation for vaccination, as well as doubt in the sense of vaccination. And it should seem worrisome, especially the last one, as these were the responses of future health care workers who will be responsible for encouraging vaccination of the public. But what is interesting is that as much as 98% of respondents had a positive view on influenza vaccination, and even 84% of them believed that this should be a mandatory vaccination for the healthcare employees. And referring to other arguments, we would like to show you the number of vaccination points in Silesia. And you can ask yourself a question whether the argument for not having vaccination because it's considered as difficult to obtain is accurate. And however, clinical classes proved to be a significant determinant of whether or not accepting vaccination, as almost 60% of those students who had already had contact with a patient decided to vaccinate. So therefore, it can be concluded that practice raises awareness. And most of the students answered that they would be encouraged to vaccinate by a free vaccination campaign at the university. And this is noteworthy and moreover supported by research, as we found a study conducted in Spain comparing vaccination rates before and after free vaccination campaign at one of the hospitals. And there was an increase from 44% to almost 80% of those vaccinated. And the most puzzling differences appear among vaccination of individual mayors. And as you can see, almost 60% of vaccinated medical students compared to about 10% in other faculties. And it should be asked whether the education and promotion of prevention, which is vaccination, is at the same level in each faculty. Because it's really important to remember that each of the students will be a part of medical personnel, and most of them will have contact with patients. So that is why it's so important to educate and raise awareness. Okay. So what is remarkable is that among students vaccinated for COVID-19, as much as more than 70% were also vaccinated against influenza. So it can be concluded that this period of pandemic influenced increased awareness of people about the importance of prevention, which is vaccination. And in conclusion, the study showed what a worrisome attitude some future medical workers and healthcare workers have, and awareness should be raised in every medical and health course and field to reduce the number of influenza infections. And also vaccination campaign at the university seems to be a very promising solution to this problem. And thank you so much for your attention. And if you have any questions, please feel free to ask it.
Prosimy, szanowny jury, o zabranie głosu.
That was a very interesting presentation and interesting data, and of course, recommendation for you as medical students to conduct such campaigns for your colleagues and also for local communities. You proved that campaigns are effective, and there's the phenomenon called peer pressure. So if you recommend and you vaccinate, your colleagues will follow you. So you proved it. My only remark, I'm not sure whether I understood you correctly with this information regarding reasons for not vaccinating.
So it was a lack of fear of the flu, as such a simple disease, and also no recommendation for vaccination from doctors, other colleagues, and so on. And the most popular one was also doubt in the sense of vaccination, that they don't believe the effectiveness.
So that was actually a percentage of students who didn't want to vaccinate and had some reasons for that.
Yes.
What was the number in total?
I
percentage?
think that not vaccinated.
Not willing to vaccinate.
About 40%.
That's a lot.
Yes, it's really a lot. Yes.
Yeah, that's a lot.
And 22 of them didn't have a fear of the flu, and other reasons were less popular in their responses, but the main one was lack of fear of the flu. Of those, about 40%.
I didn't understand the general idea, but the responses were terrifying.
Yes.
Yeah. And one other thought is the discrepancies that you mentioned between among those students, among those types of studies. I think the reason for such discrepancies is that hospitals probably require, where medical students practice, they require their students to be vaccinated. In case of physiotherapies, I think it depends. So maybe that's That's why there is this difference. It will be also interesting to research what's the reason for such difference.
Yes.
Huge difference.
So the idea for the future and developing our research.
Yeah, but congrats.
Thank you.
We have, I don't know if it is question or just comment. You said that you used some statistical methods.
Yes, precision and study.
What did you compare? And because I didn't see anything on the presentation.
So there were general questions for reasons not vaccinating and why they decided to vaccinate, and also generally the determinants of whether or not vaccinating.
But for example, different medicine or physiotherapy or
yes,
different.
Also faculties.
They were compared also, yes.
The place of living.
So it would be worth to show this also on presentation. Thank you.
But there were no significant results in these areas, so we just showed the significant ones.
Yeah, so it's important.
Thank you.
Teraz zapraszamy trzecią prelegentkę. Będzie to Martyna Jaworska z tematem Medical Simulations in Opinion of Students from Śląski Uniwersytet Medyczny.
So, good afternoon. My name is Martyna Jaworska, and I will be presenting our research about medical simulations in the opinion of students from our university. So, the research was about learning effects of high-fidelity medical simulations on Silesian Medical University. And high-fidelity simulations is an innovative form of gaining knowledge used also in medicine. And the purpose of this method is an opportunity for students to learn through practice. And of course, in practice and in a safe environment. We can not only perform the medical things that we learn, but we can also confront with emotions of the patients. In order to verify the effects of education, we conducted a survey through forms, and we asked the students from our university what they think about the high-fidelity simulations. And we got answers from 106 students. Most of them were from midwifery. But also we had participants from nursing, emergency medical services, medicine, and dentistry. And some of the participants were also graduates from our university. Most of the graduates had their bachelor, but there were some with the master's degree. And the graduates were mostly from 2020 and 2021. So we asked about their expectations, and the answers were mixed, because we asked about the emotions that they had before the simulations, and the overwhelming response was curiosity, but also stress, and also fear. So the emotions were not so promising. But participants knew what to expect from the classes. They knew that they will be practicing practical skills and gaining experience. So implementation of classes, we asked about pre-briefing, which is the conversation before the simulations. And most of the participants responded that they had the pre-briefing with their teacher. And but 11.3% of the participants said that the teacher omitted the element of pre-briefing in some degree. On the other hand, debriefing, so the conversation after the classes, looks more optimistic, because only 2.8% of respondents declared that they had they didn't experience the debriefing. 28.7% experienced the presentation of the recording from the simulations, and 69.7% of students were asked for possible comments on performance. And we also asked about the importance of the teacher during the simulations, and 43%, over 43% of the respondents commented that the teacher had great impact. We asked about the state of our simulation rooms, and again, mixed responses, because most of the students said that the simulation rooms are well prepared, but lack some things, a few elements, because, for example, they lack sterile equipment. So we have to pretend that something is sterile when it is not, and it impacts the effects of the simulations. And they also highlighted the importance of standardized patient. We asked about their feelings of confidence after the classes, and most of the students responded that they feel more confident, and that the classes will impact their future work with the patients. Feelings after the simulations were much better than feelings before the simulations, because overwhelming part of the students said they felt joy, excitement, feeling of fulfillment, but also indifference, and some of them also felt the feeling of wasted time, almost 20%. So again, mixed. And we asked open question about the what would they change in the classes if they could, and those are some of the most common answers. For example, higher amount of simulation classes, and most people said that the order of classes is wrong, that it should be always exercises in the studio, then simulations of high fidelity, and only then practical classes in hospitals. But now it's mixed. The last question was about thoughts on knowledge after high fidelity simulation classes, and people answered that the skills improved mostly, and classes helped them consolidate theoretical knowledge into practice. Yes, of course. So taking into consideration all the data, we conclude that students feel stronger stress and emotions associated before class, and high fidelity simulation classes should take place after the exercises in studios, but before the hospital ones, and that simulation classes should be held more often than they are now. Thank you.
I have one question. What was the title of your presentation of your work?
It was medical simulations in opinion of students from Śląskiej Uniwersytet Medyczny in Katowice.
Okay, so it was general, because I had the impression that you had it was very interesting study, but a lot of aims.
Yes, we had a lot of questions about this. It was we had over 30 questions on our survey, so it was very hard to cram them all into one. So because we just wanted to check what people think, and this is why this study is so big, and it's not as precise as we would like. And we also thought about doing another study more in depth in more focused aspect of the simulations. But this was the first one that we did, and we just wanted to check how it is.
That would be a good idea, a good recommendation, because you have a lot of aims, you have a lot of areas. You have a great recommendation for us as teachers, how to conduct the classes, how to organize, and information about emotions of students. So a lot of different aspects, and it will be fantastic to divide it into smaller studies.
Yes, we work with the teacher that is conducting the simulations here.
Yes, there are many valuable data for teachers, so I hope they will have opportunity to know this. I have a question about this fear and stress before. How do you think? What is the cause of this?
I think when we talked with the students, and we also had those simulations, so we can speak from experience, it's mostly for fear of being judged, because most of our education here is based on us being graded and judged by our teachers. So during the simulations, we have a fear that it will be graded, although they say they will not, but always there is the fear, and just being watched. And the simulations are this wonderful thing that there is no teacher in the room with you. He is somewhere behind the wall, but we have this fear as students from the age we start going to school that someone will judge us. And most of the fear and stress is based in this, that the simulations will be used as a tool to judge us, not tool to teach us. Thank you very much.
I zapraszamy następną osobę prezentującą. Będzie to Monika Zaborska z tematem Evaluation of Physical Activity Among Pregnant Women.
Good afternoon. Welcome, ladies and gentlemen, to your jury. My name is Monika Zaborska, and I represent Faculty of Medicine, University of Silesia. Regular physical activity is one of the most important elements of a healthy lifestyle. Nowadays, it is believed that all women with physiological pregnancies without medical contraindication should aim for regular physical activity in order to prepare for the labor and faster recovery from the delivery. At least 150 minutes of moderate intensity regular physical activity per week is recommended. Moderate activity includes walking as a fast rate, housework or gardening, recreational swimming, aqua aerobic or yoga. Movement during physiological pregnancy reduces the risk of many diseases, including gestational diabetes and postpartum depression. It also has positive impact on the cardiovascular system of the mother, improving the perfusion of the placenta and oxygenation of the fetus. The aim of our study was to assess the lifestyle in terms of physical activity in pregnant women. The choice of the research topic was dictated by a small amount of publication on the subject. In addition, we wanted to assess if negative stereotypes about physical activity are present in our society. A study population consisted of 539 women. Our original survey question was used, including 10 questions about sociodemographic characteristics of the respondents and questions about physical activity. Data were collected traditionally, paper version, and electronically, using groups for pregnant women on the social networks. The study was voluntary and anonymous. The results were analyzed using Excel and Statistica. In order to verify the statistical significance of the obtained result, we conducted the Pearson chi-square test and the non-parametric Whitney-Newman U-test. The study was well received. We obtained positive feedback and we gladly answered the questions. The average age of the examined women was 30. The youngest one was 17 and the oldest one was 37. In addition, half of the respondents were pregnant for the first time. Most of the women lived in the urban areas, and most of them had a university degree. Only 35% of examined women were physically active during pregnancy. Our study indicates that there are observed statistical relationship between the level of education and physical activity during pregnancy. As the level of education increases, the amount of women who are physically active is higher. Place of living didn't matter. Among those who were physically active, more than half reported that exercise had a positive impact on their well-being during pregnancy, especially in case of older women. Among physically active women, walking was the most common form of activity. Other most frequently chosen forms of activity includes exercise using ready videos posted on the internet, yoga, swimming, and hiking in the mountains. Almost half of the pregnant women devoted to physical activity from 2 to 3 times a week. Only 38 of examined women were encouraged to participate in sports during pregnancy. As many as 1 of 5 pregnant women received recommendation from their friends or family members to avoid physical exercise during pregnancy. As our study indicates, perceptions about pregnant women are changing very slowly. Stereotypes about movement during pregnancy are still present in our society. The research showed that the number of women exercising during pregnancy is not satisfactory. There is a need for education because pro-health behaviors affect not only the child, but also pregnant women. For this reason, it is necessary to promote awareness of the benefits of the supervised physical activity among pregnant women. Healthcare workers should encourage women to engage in regular physical activity during pregnancy. And that's all. Thank you for your attention.
I would like to ask, what did you mean by physically active woman? It was how did you measure this?
According to American Committee of Obstetrician and Gynecologists, physically active woman is a woman who devoted 150 minutes for being physical active per week.
Thank you.
That was one of the most beautiful presentations I have seen. I have few questions about questionnaire. I assume that you assumed that all those pregnancies were healthy without complications,
no.
or did you have a question about this?
Yes, we had that question.
Exclusion
and we
criteria.
excluded women who had medical contraindication and just can't be physically active.
Mm-hmm. And second question, did you have a question about the stage of pregnancy?
No,
the
we
month?
don't have that question.
Mm-hmm.
But also according to ACOG, women should be physically active during whole pregnancy.
Mm-hmm. Okay, so you address that because sometimes there's women can be very active physically, but during the first trimester is different. And did you ask them whether they were actually physically active before pregnancy? That's something that's their habit?
Yes, we had that question. And this is very important because women who are physically active professionally before pregnancy can continue this activity after consultation with the gynecologist.
Mm-hmm.
So yes, this is very important.
And last question, did you find a correlation between the place of living and physical activity?
No, as I said previously, there are no significant correlation. We only find correlation between the level of education. And physical activity, but place of living didn't matter.
Mm-hmm. Interesting. Thank you.
Thank you.
And now, teraz będzie Wojciech Suchecki z tematem self-medication used by adult patient with acute rhinosinusitis in comparison to EPOS 2020 guidelines. Niestety się zmienia. Działa? Okej, dobrze, jednak działa. Super. Proszę bardzo. To będziemy... Okej, ładnie się. Już bez mikrofonu, czy z mikrofonem? Mikrofon. Okej. Okay. I'm Wojciech, and I'm from Wrocław Medical University. I am glad to speak to you. And the title of our presentation. Let's start. Acute sinusitis, it's known as the common cold. It's one of the problems that is both small and big at the same time. Small from the perspective of an individual, from whom is not a serious health problem and is often underestimated. However, in a broader perspective, due to the scale of the disease, it's the reason for the gigantic costs it's generated for the health system. This is plan of our presentation. ARS is an infectious disease which is caused in over 98% by viruses from many different families, including rhinoviruses, adenoviruses, and coronaviruses. Ciliary dyskinesia is the following a viral infection is the pathophysiological base of the development of symptoms of ARS. And it's proven that each of us catch a cold 2 to 5 times a year. Therefore, the number of cases worldwide is very high. The effect of scale means that the global direct costs related to the, among others, a doctor's visits or treatment, and indirect costs, due to, for example, absenteeism from the work, are burden our health care system around the world. By examining the level of knowledge in the society, inventions can be prepared and planned in appropriate way that will contribute to the increasing awareness, knowledge, and adherences to the recommendations. The main aspect addressed in the study is the treatment used by patients and its compliance with the latest EPOS 2020 guidelines and the main sources that patients consult to learn about treatment. 410 people
took part in the study. The age of the participants ranged from 18 to 72. Men constituted 21% and women 78%. The subjects were recruited in the variety of ways. Representativeness of the group has been obtained by application procedural way, and the specimen has been received by a random individual one-stage unlimited selection. Almost 76% of respondents have already encountered the concept of ARS and equate this distinction with a common cold. 78% of respondents consider that viruses as the etiological factor of ARS, 55 bacteria and 40 fungi, respectively. Not all respondents realize that most often they are viruses, but the level of knowledge was still very high. More than half believed it was caused by bacteria. It is true, but in only from 1 to 2% at all. That's it's too much. And fungal infections are casuistic nature. In order to determine the intensity of ARS, we used the VIA scale. Most of the severe patients rate their symptoms moderate to severe. And in the event of infections, less than 43 of the respondents would go to the doctor's appointment. What is interesting, patients, despite the indication of high nursing of symptoms on the VIA scale, consider ARS to be such a trivial thing to go to the doctor's appointment. The waiting times are probably discouraging for the doctor's visit. According to the result of the survey, 60% of the respondents would undertake treatment on their own. The charts show the most common self-administered medications. Most of the respondents, if they observed ARS symptoms, would use NSAIDs, and a large percentage of people would also use nasal decongestants and nasal irrigations. Medicaments that have been effective proven treating... medicaments that have been proven effective in treating symptoms of ARS, and they are proposed by EPOS 2020, are marked with the thumbs up. The high percentage of people who use antibiotics, the high percentage of people who use antibiotics is worrying. This action can do more harm than good, which has been proved many times, and each of us know it. Vitamin C was very often a drug of choice in the therapy, and due to the latest medical research, does not have any positive effect on the treatment of ARS. Comparing a frequency antibiotic use in Polish and French society, we see that Poles use this preparation 60 times more often, and almost 20% of respondents will use this drug, and only 1 to 2% have such an indication. This is one of the most important observations, our observation and needs an intervention. Physicians should remind patients that it's not always a good choice for them. This slide presents a comparison of applied treatment depending on the education. We extracted people connected with a healthcare from the study population and compared the answers with the answers of all population. We were using chi-square test, but in IATES modification, and the population of medical education patient was 87 people. Consists of medical student, nurses, paramedics, medical specialists, and practitioners. In our study, we observed significantly statistically differences in the choice of treatment in favor of physicians in the use of NSAIDs and decongestants in the treatment. As for the other drugs, the results in the both groups were very similar. What is worrying, a large percentage of medics would use antibiotics treatment of ARS, which puts them in a very bad light in the terms of knowledge about the etiological factors of this disease. You may find some of the answers given by participants are ridiculous, but we need to remember we are talking about health and life, so every false belief in the society is probably dangerous. The largest percentage of people of the responses, we seek information of IRS from family physicians. Therefore, it would be a good idea to conduct education campaigns with the participation of these groups. And the results, the concept of IRS is known in the most of the population that we studied. A large percentage of respondents consider bacteria as an important epidemiological factor. Most of the respondents would go to the doctor's would not go at the doctor's appointment. Most of the respondents would use vitamin C as the drug of choice. Compared to the non-medics, medics who used appropriate drugs such as NSAIDs and decongestants statistically more often. And the frequency of antibiotic use among physical is pretty worrying. And the Polish society and the medics themselves also require through educational activities to improve self-awareness and reduce the increase of ARS. Thank you.
Jest właśnie połączone. O, teraz. I think we had a roller coaster of all emotions. Good news, bad news. Those antibiotics are indeed alarming. But there's also a positive opinion that our main source of information is not Dr. Google, but GP. So that's a positive thing. Very interesting data. And I think a lot of recommendation for you as medical and for GPs and all healthcare professionals to educate and inform patients about proper treatment.
Thank you.
I would like only to ask about the group of respondents. Maybe I didn't pay attention. It was general population or there was some specific group?
No, it was, thank you for the question, first of all, but it was general population, mostly out of Poland, but the lower Silesia voivodeship, but some of the people may be from other countries because our survey was made in Polish, but we know some of the patients that give answers were from Polacks from other countries, like living in other countries, because they type it in our survey. Mm-hmm. Yeah, and we know we also have not many men, but we still collecting answers, and we are trying to reach them by giving our survey by going with our survey to places where the men's where are the men's hobbies, like groups on Facebook where about fishing, hunting, etc.
I don't know if what you were said about this is good news, because there can be different way of treatment in different countries, for example. So maybe it's should be then somehow check, or maybe you should divide the group. I don't know, or maybe there are some few people.
Yes, we based on the EPOS 2020 guidelines formed from European Association to standardize the way of conducting the therapy among the countries of European countries.
Yeah. Mm-hmm. So those were European guidelines. So in every
but education of people can be different in different countries.
Yes,
and
but people
have different approach.
Yeah. The people from other country were like less than 1% of our survey. They were, but they were so minor, so I don't think it's really matters.
And congratulations for very clearly way of showing data, and yeah, it was very
Thank
good.
you.
Dziękujemy. Zanim zaproszę kolejną osobę, tutaj też taka uwaga do osób, prośba do członków komisji, którzy są połączeni online, także prosimy o zabieranie głosu w trakcie dyskusji. A kolejną prelegentką będzie Justyna Danel z tematem Glass Ceiling in Academia, Women's Career Paths at the Medical Faculties in Poland.
Honorable Committee, dear colleagues, on behalf of our research team, our supervisor, and Polski Medycyny Foundation, I would like to present the study about women's career path at the medical faculties in Poland. As we all know, we think about our time as equal for all. Unfortunately, women still face difficulties at school, at work, and it's the difficulties that according to their gender. And these difficulties does not bypass medical either. So it raised the question, do gender in medicine matter, or do women gender in medicine matter? Oh, okay. Medicine is one of the arts that is known to humans for ages. And I think I will not say anything revealing, highlighting the fact that the women are those who had to fight their position in it. And with many obstacles and limitations, they still have persevered in their quest to education and have a career in the discipline. But with merely 15% of women among medical graduation in 1945, we raised to 71.1% in 1973. Unfortunately, in 1985, there were a new legislation that allow only 50% of women and 50% of men to become medical graduates. And the regulation was withdrawn 2 years later because of their discriminatory character. And now, the present. We have not such legislation to determine how many women can be on the medical fields, but we see that the most majority of females are students. The majority of nurses practicing in Poland are females. The majority of physicians practicing in Poland are women, but men are still the ones who are more likely to have bigger positions in hospitals or have the highest academic positions. So the aim of our study was to find existing gender inequalities in academia careers at Polish medical faculties, highlighting their existence and define their possible causes to support women in medicine and science. Our study assessed the percentages of women at various medical fields and at various medical positions. Our database was built on two main sources. We collected data from Central Statistical Office for our request, and the data was not published to the date we proceeded. And also we collected data from 11 Polish universities. And the data was from 2017 to 2021. And we collected numbers of women and men working and studying at medical universities as PhD candidates, academic teachers, head of departments, of professor of medicine. And how was the career path of medicine of women at medical faculties? So, female PhD candidates accounted for maximum of 69% of all PhD students. At the same time, only 59% of academic teachers were female. Not even 50% of the heads of the departments and clinics were women at the time described, so between 2017 to 2021. In 2021, the percentages of a female professor was as low as 40%. So we seek for any positive change that we may took from our study. So in the analyzed years, the percentages of hospital runs by wards runs by women increased by slightly more than 3%. However, the trend was not statistically significant. And what was the key point of our study was to see if the differences between women on the different paths of medicine, the different levels, are the same. And as our study showed, they aren't. As you can see, except for PhD candidates and the academic teachers, different levels we contributed to a different percent of women. So starting with a 17% of a female students, we ended with merely 40% of professors that are women. And we done a hypothetical path of the women that are starting the medical journey at the 11 medical universities that we included in our study. And the main conclusion was that women are disappearing, and we question why and where. The highest the title or the degree was, the greater the differences between promoted women and men were. And despite the passage of time, I think we should highlight the words of Renata Siemiński from her paper from 2009, in which he noted that the opening access to the education for women that are taking place in Europe and United States does not mean that the professional academic career is as obvious for women as it is for men. So according to our study, despite being the majority of PhD candidates, the percentages of a woman and the highest rank is noticeably lower than a man. So thank you for your attention. I'm happy to answer all of your questions.
I have a conflict of interest. I am a woman. So that will be a problem for us, I guess. That's actually a very, very important topic. And we are aware of that there's actually no solution for that. We know that your professional group is highly consists mainly of women. We see this in the classroom. We see this in the statistics in the National Chamber of Medical Professionals. And the problem indeed is that, of course, we have a lot of PhD students, women, because you finish one studies, you go to study another, but then you, as you said, you disappear. Why? Because you have usually two careers. You have to, most of you want to combine professional career with personal life, and it's very difficult. And I think the thing that we should do and we can do as women is to talk about this and motivate each other, address our concerns, challenges that we have as professionals and mothers, caregivers, and try to break this ceiling. And I think while it's relatively easy to become an academic teacher while you're still a woman, it's very difficult to become professor of medicine and practitioner. So there are a lot of challenges, but the most important thing is talk about this and unite. It's not a feminism or anything like that. It's a need for our community to unite.
Thank you for your opinion. It was one of the like the main aim for our study was to like highlight the problem.
It's very interesting topic, but I would like to ask if did you make any research about the reason why is it like that?
Yeah, we kind of did, but it's as obvious as we can think of. It's the society thinks of role for women, but also that the women really wants it all. They want to have a healthy family and want to have a career, but in some point they have to choose. And because we live in a country that I don't know if it's a country or it's a culture, we live with the thing in mind that women are those who had to stay and take most of the care for home. And I think one of the aims of our studies also to highlight the possibility for men also to participate in the home.
Yes, I think it would be very interesting to ask women and men, because I think that the first thought we have seeing these results is that there is some kind of discrimination, but actually it is possible that women just don't want to have this higher position, heads of department and so on, and they prefer have maybe more calm life. So it's interesting.
Thank you.
Dziękujemy. Teraz chciałbym zapytać gwoli ścisłości, czy Jolanta Płonka albo Mateusz Krzempek się pojawili, albo są z nami połączeni online? Jeśli nie ma, to przechodzimy zatem do kolejnej prezentacji. Prelegentem będzie Ryszard Feret z tematem Mental Health of Medical Students, Jagiellonian University Medical College Example. I tutaj prosimy bardzo o wgranie prezentacji, bo uczestnik jest połączony z nami online.
Dzień dobry, tylko tak szybko, czy mnie widać? Chyba mnie widać, tak?
Widzimy i słyszymy.
Tylko muszą Państwo wyłączyć udostępnianie ekranu, bo ktoś innego udostępnia, więc ja nie mogę. W sensie muszą Państwo wyłączyć na chwilę udostępnianie. Bo mam tutaj komunikat, że nie mogę udostępniać ekranu, jeśli ktoś inny udostępnia.
Jest problem techniczny, że jeżeli właśnie my prowadzimy transmisję, to chyba my musimy udostępnić, więc po prostu chyba będziemy musieli wgrać Pana prezentację, którą mamy. Matylda, masz temat ustny. I jeżeli chodzi o zmienianie slajdów, to powiem Pan po prostu, żebyśmy przeklikali na kolejny. Bo chyba inaczej nie jesteśmy w stanie technicznie na ten moment tego rozgraniczyć, tym bardziej, że tutaj nie mieliśmy w Pana przypadku informacji, że będzie Pan uczestniczył online, bo mieliśmy zapisane, że będzie Pan tutaj na miejscu. Więc spróbujemy, mamy nadzieję, że się uda, więc za chwilę prezentacja zostanie wgrana i będziemy zaczynać. Czy Pan widzi teraz u siebie prezentację?
Właśnie u siebie na komputerze, czy u Państwa?
Czy widzi Pan udostępnioną z naszej strony Pana prezentację? Powinna być widoczna teraz.
Widzę na ekranie głównym, że tak to powiem, przynajmniej Państwo widzę, o tak. Nie widzę Państwa ekran chyba, tylko... Krzysztofa? Ryszard Feret. Właśnie, ja u siebie na komputerze mam ją uruchomioną, więc mogę ją postarać. A, czyli już mogę. Okej. Dobrze, dobra, to sekundka.
Dobrze, w porządku.
Dobrze, to proszę mi powiedzieć, czy widać w takim razie prezentację?
Tak, widzimy i słyszymy i zapraszamy do prezentowania.
Okay. Ladies and gentlemen, at the beginning I would like to apologize that I'm not stationary, but unfortunately to personal matters I had to participate remotely. I have the pleasure to present scientific papers on mental health of students of the Jagiellonian University Medical College. The person who has the honor to answer the question is Urszula Durla. The topic of mental health is extremely important nowadays, and in cooperation with the university authorities, we decided to check how it looked at our university and introduce specific solutions based on the conducted research. The analysis was conducted on the basis of 1,294 collected questionnaires from 5,255 students of Jagiellonian University Medical College. The survey was collected in the period of January 13 to February 12. The research methodology was based on a survey with between 21 and 25 questions, depending on the chosen answer. The survey was divided into 4 sections and was completely anonymous. Wait a second, because I don't know why I can't.
Właśnie jest jakiś problem techniczny, bo u nas się w ogóle slajd nie zmienił. Jest cały czas pierwszy slajd widoczny z pana tytułem pracy.
Now? Do you...
O, tak,
okay right now?
Tak, teraz się zmieniło.
Okay, sorry for my problems. Okay, so one of the first question was on the scale of 1 to 10, how would you rate your knowledge of mental health? So the average grade taking into account of all fields of study was 7.1 points and did not differ significantly between faculties. One thing that is very important to emphasize is the high level of knowledge of medical students about mental health. The most frequently selected grades were 8, 9, 6, and 7, respectively. Okay. The next question concerned the sources of knowledge from which students obtain information on mental health. We can see that the sources of knowledge about mental health among students of the 3 faculties are very similar, in particular social media, popular science sources, and texts of culture. External factors affecting the well-being and functioning of students. Students could also mark the symptoms they experienced in recent weeks and which affected their mental health and functioning. The results in each of the departments were very similar, and the most frequently chosen by students were fatigue, lack of concentration, and anxiety, and sleep problems. Students averaged their mental health at 4.74. This is very low, and I must admit that it was worrying for our university. And in the future part of the survey, we wanted to find out the reason for such low ratings. In the study, we also checked how many students through they needed psychological support during the period. In this case, almost 72% of students of the Faculty of Medicine, 54% of Faculty of I have a mistake here. 64 Faculty of Health of Science, 54 Faculty of Medicine, and 25 of Faculty of the Pharmacy needed support. But as we can see, most students did not use the help of physiologists. In the case of the Faculty of Medicine, about 60% did not use it, Health Science about 70%, and Pharmacy 75%. The rest of the students used support in some form or did not want to answer the question. The main reasons why students, despite the need to use a psychologist, did not use it were high prices, lack of time, and distant appointment with a specialist, or difficult to find a good specialist. Okay, but when it comes to the need for psychiatric help, we can see that in the case of the Faculty of Health Sciences and the Faculty of Medicine, almost 35% of the students need psychiatric help. In the case of the pharmaceutical faculty, almost 55% of students need a psychiatric help. But how many students use the help from the psychiatrist? In the Faculty of the Health Sciences and the Faculty of Medicine, about 13% used the help of the psychiatric, and in the pharmacy faculty, about 33%. As in the case of the psychological help, the reasons for not using it were very similar, and they were primarily financial issues, lack of time, distant deadlines for the National Health Fund, and difficult to find specialists where they would feel comfortable. In our research, students could also share their diagnosis with us, and as many as 284 of 1,294 who took part in the study entered their diagnosis. In 55% it was depression, and in 45% anxiety disorders, borderline personality disorders, eating disorders, bipolar were also very common. Solutions. We can see that the mental health of students of the Jagiellonian University Medical College is not in the best condition. As we as the Student Council and as the university authorities have initiated numerous actions to improve their mental health. Students of these faculties are particularly vulnerable to poor mental health due to the number of classes, rivalries, street-related passing grades, and as well as the responsibility that rests with these professions, which students are aware of. We hope that similar research will accompany other universities because nowadays the topic of mental health is extremely important. And thank you very much. And I'm giving voice to Ursula. Would like to answer your questions. Thank you.
Dziękujemy bardzo za to wystąpienie. Pomimo trudności technicznych udało się nam. Teraz poprosimy jeszcze komisję o zadanie pytań.
Thank you for this presentation. I have to say that I'm speechless and I don't really understand. You as medical students diagnose yourself perfectly. You have depression, anxiety, bipolar disorders, all those disorders named, and your main source of information and knowledge is social media.
Thank you for your opinion. Yes, in our point of view, it's also a very big shock that so many people has knowledge from social media, and I think we really need to educate people at universities or start organizing some events to know mental health and how to prevent professional burnout and prevention of mental health disorders in a professional way.
Mm-hmm. But I think it's also very recommended to guide students where to look for information on mental health, because social media is not the source, and you have all sources in front of you. You have an access to reliable sources, to authorities, to gain reliable knowledge. We cannot expect our patient to go to. It's not a remark to you, but I'm so shocked that I'm emotional now. We cannot be surprised that our patient use Dr. Google if we use Dr. Google to diagnose us and to get some knowledge. So that's those results are really shocking. But coming back from this shock, did you apply any statistics to your studies? What's the difference between those faculties? We saw charts, but we don't know whether there was a significant statistical significance between those groups.
Yes, there were some. The Faculty of Medicine, there were the most questions, the most answers. it was above 500 answers. And in the Faculty of Pharmacy, it was about 360 voices, and the rest it was from health of Faculty of
Health Sciences.
Faculty of Health Sciences. Yes, sorry.
Those are the just numbers. So you should apply some statistical tools to be able to say which group has the worst outcomes and to issue reliable recommendation and diagnosis in particular group.
We have been using the Statistica and other methods, but with the help of our deans, because we have made after this sciences, after this research, we have made a report to our university, and after this, with help of our deans and rector of our university, we are introducing some new programs like workshops to help students to deal with the stress and with the mental health problems. But yes, we have checked that the problem is significant and it's statistic important. But like at this time, I can't give the number of from Statistica. I'm trying to find it.
One more comment, if I could recommend you, if you want to dig deeper into this topic, please use standardized questionnaires. There are a lot of questionnaires assessing mental health, VEX, depression inventory, PH9, many tools that will help you to have more reliable and comparable results.
Yes, of course. We also supported ourselves with psychological questionnaires, as you said. And before showing the questionnaires for students, we first of all we asked our psychiatry professors to check it. So it was checked, and this data that we are showing you today, it's only a small part of this questionnaire. So maybe that's why.
Yeah.
It's looked that way.
Okej, dziękuję. Niestety musimy już przerwać, bo czas się skończył, ale dziękujemy bardzo za wystąpienie. Brawa.
Dziękujemy bardzo.
Dziękuję bardzo.
I kolejna osoba to Angelika, czy też Angelika, nie wiem jak wymawiać, Gąsiorczyk, z tematem pracy o tytule The Patient's Knowledge of the Prevention, Treatment and Monitoring of Blood Pressure Disorders. I jeszcze taka prośba do poprzedniego prelegenta, żeby przestał udostępniać ekran, żeby zatrzymać to udostępnianie ekranu. Okej, oddaję.
Chciałabym serdecznie powitać wszystkich tutaj obecnych. Nazywam się Angelika Gąsiorczyk i wraz z kolegami chciałabym przedstawić wyniki badań na temat wiedzy pacjentów o prewencji, leczeniu, monitorowaniu zaburzeń ciśnienia tętniczego, a skupię się dzisiaj głównie na nadciśnieniu tętniczym. Dzisiejszą prezentację rozpocznę od omówienia skali problemu, jakim jest nadciśnienie tętnicze. Następnie przejdę do omówienia metodyki badania, a także charakterystyki respondentów. Kolejno omówię wyniki badania dotyczące wiedzy pacjentów na temat prawidłowego mierzenia ciśnienia tętniczego, a także interakcji lekowych i działań niepożądanych związanych z terapią. Pod koniec prezentacji przedstawię Państwu rolę, którą może pełnić farmaceuta w informacji i edukacji pacjentów. A prezentację zakończę przedstawieniem konkluzji. Nadciśnienie tętnicze to bardzo poważny problem, ponieważ dotyczy ponad połowy polskiego społeczeństwa. Dodatkowo sama efektywność leczenia jest dość niska, dlatego również podczas naszej prezentacji chcielibyśmy zwrócić tutaj uwagę na rolę, którą może pełnić farmaceuta w właśnie edukacji pacjentów. Badanie zostało przeprowadzone za pomocą ankiety anonimowej między styczniem a kwietniem 2023 roku. Ankiety zbierano w aptece ogólnodostępnej, na spotkaniu Uniwersytetu Trzeciego Wieku, a także za pomocą ankiety online. I zebrano 275 ankiet. Wśród ankietowanych największą część stanowiły osoby po 60 roku życia. Spośród wszystkich ankietowanych prawie 40 leczyło się na zaburzenia ciśnienia tętniczego, natomiast jeśli chodzi o stopień edukacji, to większość ankietowanych posiadała wykształcenie średnie lub wyższe niemedyczne. Przechodząc do wiedzy na temat nadciśnienia tętniczego, to pomimo, że ponad 60% ankietowanych jest przekonana, że posiada wiedzę na temat prawidłowego mierzenia ciśnienia tętniczego oraz jego wartości, od której go rozpoznajemy, to niemal 40% nie zna granicznej wartości nadciśnienia tętniczego. Ponadto ponad 60% respondentów nie wie, na której ręce prawidłowo powinno się mierzyć ciśnienie tętnicze, a około 30% nie zna większości czynników, które mogą wpływać na wartości ciśnienia tętniczego, takie jak na przykład palenie tytoniu, wysiłek fizyczny i umysłowy oraz picie napojów zawierających kofeinę przed pomiarem, czy też złe umiejscowienie rękawa ciśnieniomierza. Przechodząc kolejno do interakcji i działań niepożądanych związanych z terapią nadciśnienia, to ponad 40% ankietowanych leczących się na nadciśnienie tętnicze nie zdaje sobie sprawy, że popularnie stosowane leki na przeziębienie, takie jak Gripex czy też Theraflu, a także leki obkurczające śluzówkę nosa, takie jak Xylorin czy też Sudafed, wchodzą w interakcje lekowe i mogą powodować wzrost ciśnienia tętniczego. Wiedza ankietowanych na temat działań niepożądanych również jest dość niska, ponieważ prawie połowa ankietowanych nie zdaje sobie sprawy, że podczas leczenia lekami z grupy leków moczopędnych bardzo ważna jest kontrola stężenia potasu we krwi. Co więcej, około 40% z ankietowanych nie jest świadoma również, że wysoki i zarówno niski poziom stężenia potasu we krwi mogą być bardzo niebezpieczne i powodować osłabienie, skurcze mięśni i też zaburzenia rytmu serca. Dodatkowo aż 75% respondentów nie jest świadoma, że występowanie suchego kaszlu podczas leczenia inhibitorami konwertazy angiotensyny może być działaniem niepożądanym. a ponad połowa ankietowanych nie wie, że nagłe przerwanie terapii lekami z grupy beta-adrenolityków może prowadzić do tak zwanego efektu z odbicia, który będzie się charakteryzować nagłym wzrostem ciśnienia tętniczego i częstości skurczów serca. Jeśli chodzi o rolę farmaceuty w opiece nad pacjentem z nadciśnieniem tętniczym, to większość ankietowanych wyraża chęć uzyskania właśnie porady od farmaceuty odnośnie stanu zdrowia i stosowanej farmakoterapii, lecz ze względu na brak dyskrecji, złe warunki w aptece nie robią tego. Dodatkowo nasze wyniki wykazało, że ponad 80% respondentów uważa, że farmaceuta powinien mieć wgląd do przyjmowanych przez pacjenta leków, co także pozwoliłoby ograniczyć interakcje lekowe i zwiększyć samo bezpieczeństwo terapii. Podsumowując, mimo że problem nadciśnienia jest bardzo powszechny i większość pacjentów tak naprawdę nie posiada satysfakcjonującej wiedzy na ten temat, co mogłoby ta edukacja pacjentów mogłaby być między innymi realizowana dzięki właśnie opiece farmaceutycznej. Ponadto świadomość na temat interakcji i działań niepożądanych również jest dosyć niska, co również stwarza potrzebę jakby dalszej edukacji. A z kolei biorąc pod uwagę, że problem nadciśnienia tętniczego głównie dotyka właśnie osoby starsze, które często zasięgają porad wielu specjalistów, to jest tutaj ogromne pole do interakcji lekowych. Co prawda pacjenci wyrażają chęć konsultacji właśnie tej farmakoterapii z farmaceutą, jednak wciąż w większości aptek nie ma odpowiednich warunków do przeprowadzenia tego typu usług. Dlatego ważny jest również ten ruch dążący do zapewnienia osobistych pomieszczeń i przeprowadzenia tego rodzaju usługi. Dziękuję bardzo i zapraszam do dyskusji.
Meritoric value very high. I think you gave us very clear, very interesting results and very clear recommendation how to change. Przepraszam, zapędziłem się. Nie, przepraszam. W jaki sposób zmienić, nawet nie słyszałam, w jaki sposób zmienić sytuację? Macie Państwo konkretne, bardzo jasne wytyczne i ile tak naprawdę to też dla Państwa satysfakcja, jak bardzo możecie tą sytuację i te potrzeby zaspokoić, tę sytuację zmienić. Myślę, że też stworzyły się trochę sprzyjające okoliczności z racji właśnie paradoksalnie pandemii COVID i tych szczepień, gdzie jednak została jakaś w wielu miejscach stworzona taka bardziej bezpieczna i bardziej dyskretna przestrzeń. Dobry moment też, by wykorzystać właśnie to doświadczenie takich usług, tym bardziej, że macie Państwo feedback prosto od pacjentów, że chcieliby skorzystać i że widzą taki potencjał w Państwa, że chętnie by skorzystali z pomocy. Taka mała uwaga, gdybyście Państwo już chcieli to publikować, to ja pokusiłabym się o stworzenie takich jednak exclusion criteria i wyłączeniu tych osób, które mają jakiś medical background. I w tym momencie mielibyście Państwo bardziej taką właśnie, przynajmniej jeżeli chodzi o to wykształcenie, homologiczną grupę, też myślę, że to mogłaby być jakaś taka uwaga recenzenta, żeby jednak tych medyków czy z wykształceniem medycznym wyłączyć. Ale świetne badanie, jest pod wrażeniem.
Tak, na pewno bardzo ważny temat i jeszcze mogę dopytać o grupę, tam była średnia 60 ileś lat wieku, czy to było?
To było ponad 60.
Średnia, tak? Średnia? Bo może to jest na slajdzie, nie wiem, bo nie...
Tak.
Osoby, że tam 26% osób to stanowiły osoby po 60 roku życia po prostu, ale nie mieliśmy tak jakby po 60 roku, już nie sprawdzaliśmy dokładnie wieku tych osób.
A średnia nie... Nie są Państwo w stanie powiedzieć, bo też zastanawiam się, tam dosyć stosunkowo niski jest ten odsetek osób, które są poddane terapii, 30 chyba ileś procent. Zastanawiam się, czy mogą tu być jeszcze w tej grupie osoby, które nie wiedzą w ogóle, że mają nadciśnienie.
To znaczy, bo wyłączyliśmy, nasza ankieta dotyczyła również takich zaburzeń jak niedociśnienie tętnicze. I w tym momencie po prostu do tej grupy, która jest nieleczona, włączyliśmy też pacjentów, którzy leczą się na niedociśnienie, żeby bardziej, bo chcieliśmy sprawdzić, czy jakby to, że chorują, ma jakiś wpływ na ich stan wiedzy. Niestety okazało się, że pomimo tego, że się leczą, często nie zdają sobie sprawy z takich podstawowych rzeczy i nie wiemy, czy to jest kwestia tego, że po prostu nie chcą dopytywać lekarzy, czy może lekarze ich nie informują, czy może też nie są informowani też o tym w aptece, bo to też jest taka kwestia, którą można poruszyć podczas po prostu wydawania leku pacjentowi. I nie chcieliśmy po prostu zaburzać tutaj tej równowagi pomiędzy po prostu tymi leczonymi na nadciśnienie, w momencie, kiedy skupialiśmy się w naszej prezentacji głównie na tym nadciśnieniu.
Organizacyjnie, formalnie zapytam, czy ktoś z następnych kolejności prelegentów nie zjawił się albo nie jest połączony z nami online. Julia Woźniak, Maria Partyka albo Sabina Kadłubek. Nie słyszymy, także kolejna praca będzie prelegentką Julia Nieśpielak. Temat pracy: The influence of caffeic acid on breast cancer cells of the MCF7 line.
Good afternoon. My name is Julia Nieśpielak, and today I'm honored to represent the Department of Pathology of Pharmaceutical Sciences faculty from Medical University of Silesia in Katowice. The topic of our presentation is evaluation of caffeic acid influence on breast cancer MCF7 cells. And the subject of our research was breast cancer because it is the most common type of cancer that affects women globally. In Poland, just in the last 4 decades, the morbidity of breast cancer increased by 200%. Currently, it is treated with chemotherapy and surgery, but there is a growing demand for new therapies, like natural medicine. Natural medicine uses cytotoxic metabolites from plants, such as caffeic acid, which was the compound of our research. We investigated the cytotoxic effect of caffeic acid on viability and proliferation of breast cancer MCF7 line cells. As I said previously, we worked on MCF7 line cells. We cultured them on EM medium in standardized conditions. To evaluate the cytotoxic effect, we use a combination of methods such as AG staining to picture the morphology of cells, the MTTSA test to evaluate the viability of cells, and the D1 healing test to evaluate the living cell migration. These are the results of AG staining. On the left side, there is a control group. On the right side, there is a tested group. As you can see, after applying 25 micromoles of caffeic acid, the number of cells hasn't changed much. The cells still have plenty of cytoplasm. The nuclei and nucleolus stayed roughly the same, but as we can see, the cytoplasm profusions visibly shortened. The MTTSA test is a test that evaluates viability of cells. On this line graph, we can see that caffeic acid lowers the viability of cells depending on time and dosage. After 24 hours, which is pictured by dark purple line, we can see that every concentration equal or higher than 50 micromoles was statistically significant in decreasing the viability of cells. After we prolong the incubation for the next 24 hours, we can see that every concentration that we evaluated was statistically significant in decreasing the viability of cells. Based on MTTSA test, we calculated the IC50 concentration, the IC50 value. IC50 value is a concentration that inhibits proliferation and viability by 50%. And as you can see, prolonging the incubation time for 24 hours statistically significantly decreased the effective concentration of caffeic acid on breast cancer cells. The one-healing test is a test that evaluates the living cell migration by making a scratch on a cell monolayer and capturing changes in intervals. In these pictures, we can see migration of untreated cells. So this is the control group without any caffeic acid added. We can see that after 24 hours, cells started to heal the wound. After applying 25 micromolar concentration of caffeic acid, we can see that cell migration inhibited a lot, and after 24 hours, the wound surface area is much larger than compared to the control. However, after applying 50 micromolar concentration of caffeic acid, we see no statistically significant changes, and after 24 hours, the wound surface area is very similar compared to wound surface area after applying 25 micromolar caffeic acid concentration after the same time, after 24 hours. And this bar graph shows that increasing the concentration of caffeic acid was not statistically significant after 12 hours. Changes were observed after 24 hours, and 50 micromolar concentration showed the strongest inhibitor, but it was still not statistically significant. In summary, caffeic acid has a cytotoxic effect on the viability and proliferation of MCF7 breast cancer cells. And thank you for joining us today. These are the sources that help us prepare for this presentation.
I would like to ask you about your participation, because here you used some laboratory methods. So did you do this alone with a team, or?
Thank you for your question. We evaluated the cells, helped to culture the cells with the help of our works tutor, Anna Kleczka, PhD, from our department, and also prepared the abstract and evaluated the wound healing test and prepared the presentation for today.
We also observed and evaluated the morphology under the microscope.
Thank you. I have only such comment that this work, maybe it should be in another session with some experimental medicine or something like that, because it's hard to compare this work to this which were before, but it was very good.
We choose this session because the cancer is a global problem, yeah? It's the main cause of that of death in population, and we are not clinicians. We are working on prepared cells from the base. So this is why we choose this session.
Thank you.
Teraz zapraszam Macieja Rzepkę z tematem Blue Light Blocker Effectiveness in Age-Related Macular Degeneration.
Good afternoon, ladies and gentlemen. My name is Maciej Rzepka. I am a member of Scientific Society of Department of Ophthalmology in Katowice. And today I would like to present to you the effectiveness of blue light blockers in age-related macular degeneration. I decided to divide my presentation into 5 parts: background, aim of study, methods, results, and conclusions. Many experimental studies that were run around the world have clearly shown the link between exposure to the blue light and damage and death of retina cells, including RPE, which is retinal pigment epithelium, and photoreceptors. As a consequence, blue light has been suggested to increase the chances of developing AMD, as well as enhance their progression and severity of age-related macular degeneration. The aim of our study was to show what will be the impact of reducing blue light exposure by using glasses with blue light filter on quality of life among people that are suffering from macular degeneration. Okay, to perform our research, I decided to use the Billard test, in which the first step of that Billard test was to check the visual acuity of patient. Then we had to dazzle the patient's retina for about 10 seconds and measure time for complete retina regeneration. So when patient could once again read the same symbols from a Snellen chart. Each eye was tested separately, twice without glasses and twice with them on. We tested around 108 non-AMD eyes and 76 eyes suffering from dry AMD. We needed to gain an approval from Bioethics Committee of Medical University of Silesia. Here is the number of that approval. And before being tested, every patient's intraocular pressure was measured using the non-contact tonometer, which is seen here to the right, and to the left, the ophthalmoscope, the equipment about which I was talking about. Here is the Snellen chart. We checked we evaluated the visual acuity to the distance of 3 meters. And our exclusion criteria contained decreased clarity of optic media, eye diseases. Of course, we excluded AMD, abnormalities in alignment and mobility of the eyeballs, neurological disorders, chronic oncological treatment and immunosuppression, and the refraction error of more than -4 diopters. Table 1 shows us the mean reaction times in seconds, standard deviations, and frequencies for healthy volunteers. To achieve these results, we performed, or our statistician performed, human Whitney test. And as we can clearly see, we decided to divide the control group on those without refractive error and with refractive error up to -4. And both groups, in both groups, we saw the decrease in that time needed for complete retina regeneration after using special glasses with blue light filter. These figures show us the distribution of time among the healthy population. To the left, we see without blue light filter, and to the right with blue light filter. And as we can see, that decrease of time is clearly seen in that charts. Next chart shows us the same changes of time in control group, where 0 are the times that were measured without blue light filter, and right with blue light filter among healthy volunteers. And also we see that time here needed for complete retina regeneration after being tested with a blue light filter was decreased. Table number 2 shows us also mean reaction time, standard deviations, and frequencies for the patients with dry AMD. Patients were divided also into 2 groups that underwent cataract surgery in the past. They are with intraocular lens and without intraocular lens, who did not undergo in the past cataract surgery. Figure number 3 shows the distribution of time among all AMD patients without blue light filter, and to the right with after using blue light filter. And as we see again here, the time is decreased the same as it was in among healthy population. Next chart shows us the same distribution of time among AMD patients who underwent in the past cataract surgery. And as we see, the decrease of time is not really clearly seen in that figure, but we experience decrease of time after cataract surgery. This chart shows us the changes of time among AMD patients, and where 0 is being tested without blue light filter and 1 with blue light filter. And as we see here, also time here is increased after using that blue light filter. So, well, to sum up everything here, among healthy populations that use the blue light filter reduce the average readaptation time by about 4 seconds. And among AMD patients, about by 26.5 seconds. Increase in intraocular pressure reduced time needed for complete retina regeneration by 12.7 seconds, and pseudophakic patients, so patients who underwent in the past cataract surgery with intraocular lens, had lessened their time by 75.2 seconds on average in comparison to phakic. In comparison to phakic patients who use, but use of that blue light blocking glasses resulted in no apparent advantage. So, ladies and gentlemen, conclusions. Our results show that blue light blocking glasses significantly decrease the time needed for complete retina regeneration among both healthy and patients suffering from AMD, which can improve quality of life among patients suffering from macular degeneration, because these people can, for example, once again, for example, drive a car, which is for them a really big deal. Blue light also leads to the reduction of physiological functions of the retina much more in AMD patients rather than healthy population. And among patients with pseudophakic eyes who underwent cataract surgery in the past, we haven't found any significant improvement of retinal function after reducing blue light exposure by our glasses. Thank you for your attention.
Was very professionally designed from the start work, so congratulations. I assume that you didn't have any tool to measure the quality of life.
Well, quality of life is, well, we didn't have any tool because, well, we only suggest that because, for example, well, if I can make it a bit longer, but for example, people who had AMD or has AMD, even healthy people, sometimes when, for example, they drive a car, which is really, well, everybody does it every day. And when, for example, a car that are going to in a different direction, for example, when they look at this car, especially at their lights, they can be blinded or dazzled, as I used the same word. And among AMD patients, that time of being dazzled is much longer. So they can, for example, they can provoke a car accident, which can be fatal for them. So that their quality of life, yeah, we didn't have any tool to measure that. And but I believe that if we will introduce that glasses to a wider population of AMD patients and we will check our results in, for example, 5 or 10 years, we can measure if their quality of life has increased over the time or not. So, well, it's only what I think that it can increase their quality of life.
I understand you, but the quality of life is a very scientific concept. So we should, of course, we know that those patients will have improved quality of life, but that's our assumption. So I would highly recommend you to use a standardized questionnaire for the quality of life, to measure quality of life. Maybe there is a questionnaire for this particular group of patients with this particular problem, and you have reliable data. That's how we can measure actually the quality of life. We cannot assume. We assume that it will be improved, but we don't know really.
Thank you.
Raz.
I jako ostatni prelegent na dzisiejszej sesji zapraszamy Mateusza Szymałę z tematem Noise Assessment in Kindergarten.
Witam szanownych Państwa. Jest mi niezmiernie miło być uczestnikiem dzisiejszej konferencji. Ja nazywam się Mateusz Szymała i chciałbym zaprezentować przebieg oraz wyniki badania, które przeprowadziłem wraz z Adrianą Papierok w ramach koła naukowego pod tytułem Noise Assessment in Kindergartens i było ono pod opieką pani dr Jolanty Malinowskiej-Borowskiej. Słowem wstępu, dzieci uczęszczające do przedszkoli są to osoby w przedziale wiekowym między 3. a 6. rokiem życia. Większość swojego dnia one spędzają w przedszkolu, zatem istotne jest, żeby warunki, w których ten czas spędzają, były bezpieczne i higieniczne dla ich zdrowia. Niestety jednym z czynników uciążliwych występujących w przedszkolu jest hałas. Hałas przedszkolny charakteryzuje się wysokimi poziomami ciśnienia akustycznego, co negatywnie wpływa na samopoczucie uczniów oraz nauczycieli. Celem badania było zbadanie hałasu wewnętrznego w przedszkolach w trakcie zajęć oraz w trakcie posiłków i znajomość tych poziomów może zapobiec narażeniu na wysokie ekspozycje hałasu i zapobiec w efekcie konsekwencjom zdrowotnym z nich wynikającym. Poziom dźwięku był mierzony za pomocą sonometra SON 50 w 3 przedszkolach w 2 miastach województwa śląskiego. W badaniu łącznie wzięło udział 484 dzieci, które były podzielone na 24 indywidualne grupy. Poziom dźwięku A był mierzony w klasach w czasie obecności dzieci. Jeżeli wziąć pod uwagę wszystkie pojedyncze pomiary, jakie zostały wzięte pod uwagę, było ich 660. Dodatkowo poziom dźwięku A był mierzony w różnych grupach wiekowych, w różnych sytuacjach. I w każdej sytuacji tutaj wykonano 20 pomiarów z 1-minutowym odstępem między nimi. Do każdej z sytuacji wyznaczono maksymalny poziom dźwięku A i badanie wzięło pod uwagę wiek dzieci, liczbę dzieci oraz ich rodzaj aktywności, którą wykonywały w danym momencie. Zanim przedstawię wyniki, chciałbym zwrócić uwagę na pewien fakt, jakim jest brak wyznaczonego poziomu najwyższego dopuszczalnego natężenia dla dzieci. W związku z tym chciałbym przedstawić wyniki innego badania, w zasadzie streścić, którego autorem był Thompson i inni, i tytuł tego badania nosił nazwę Noise Pollution and Human Cognition. I celem tego badania było wykazanie występowania tak zwanych efektów pozasłuchowych, między innymi właśnie wśród uczniów, w tym wypadku tego badania dzieci szkół podstawowych. I z tego badania wynikło, że hałas o poziomie, który jest niższy niż wartość najwyższego dopuszczalnego natężenia, negatywnie wpływa na wydajność pracy. I w tamtym badaniu wskazano 3 takie poziomy dźwięku. Był to niski poziom dźwięku, wahający się od 55 do 65 dB, średni poziom dźwięku wahający się od 67 do 77 dB oraz wysoki poziom dźwięku wahający się od 72 do 80 dB. I tutaj co istotne jest to, że już od pierwszego tego poziomu, czyli tak naprawdę już od ekspozycji na 55 dB, występują efekty pozasłuchowe, do których należą problemy z czytaniem, problemy ze skupieniem się, problemy z mówieniem i to wszystko przekłada się na gorszą jakość procesu edukacyjnego. I dodatkowo w tym badaniu jeszcze wykazano, że wraz ze wzrostem natężenia hałasu dzieci, które rozwiązywały ten sam test, miały gorsze wyniki niż dzieci rozwiązujące ten sam test tylko po prostu w ciszy. I jest to kwestia bardzo istotna, no bo narząd słuchu dzieci ciągle się tak jakby rozwija, no i w narażeniu na niehigieniczne warunki rozwija się on po prostu nieprawidłowo i mogą z tego tytułu wynikać różne problemy ze słuchem. A teraz już przechodząc stricte do wyników naszego badania, prosiłbym jeszcze ten pierwszy, bo o tym jeszcze nie wspomniałem. Tutaj był zmierzony poziom dźwięku A w trakcie jedzenia posiłków, no i tutaj uwzględniona została średnia ze wszystkich zmierzonych sytuacji w danym przedszkolu. No i zgodnie z tą klasyfikacją Thomsona, o której przed chwilą mówiłem, no to średni poziom dźwięku A jest tutaj na niskim poziomie. Następny wykres przedstawia poziom dźwięku A w trakcie zabaw dowolnych. Był to moment, w którym dzieci mogły robić to, na co miały w danym momencie ochotę. No i tutaj ponownie została uwzględniona średnia ze wszystkich pomiarów, ze wszystkich sytuacji w danym przedszkolu. No i poziom dźwięku A według klasyfikacji Thomsona jest tutaj na poziomie wysokim. Kolejny wykres przedstawia poziom dźwięku A w trakcie, gdy dzieci były w trakcie wykonywania kart pracy. Zostały tutaj uwzględnione wszystkie sytuacje w danym przedszkolu, obliczona z nich średnia, no i według klasyfikacji Thomsona poziom dźwięku jest tutaj na poziomie średnim. Czwarty wykres przedstawia nam tutaj poziom dźwięku A w trakcie zajęć wychowania fizycznego na sali gimnastycznej. Z racji, że tylko jedno przedszkole miało taki obiekt, no to po prostu zostały wzięte pod uwagę 2 grupy, które mieliśmy możliwość zbadać. No i lekcje wychowania fizycznego jest to czas, w którym dzieci mogą pozbyć się swojej nadwyżki energii, mogą wyzbyć się swoich negatywnych emocji. No i niestety negatywne konsekwencje widzimy tego tutaj na tym wykresie, ponieważ tutaj już mówimy o normatywie higienicznym, który został przekroczony. Mianowicie 85 dB jest to poziom natężenia hałasu, który w żadnym wypadku nie może zostać przekroczony w odniesieniu do 8-godzinnego dobowego rytmu pracy. Już do wyników mam? Aha. Więc tutaj po prostu został przekroczony poziom 85 dB i w tym momencie mówimy, w tym momencie narażeni na hałas są nie tylko są narażone dzieci, ale przede wszystkim nauczyciele, dla których to już są negatywne konsekwencje zdrowotne, a co dopiero dla dzieci, których to narząd słuchu w ciągłym stopniu się rozwija. Dodatkowo jeszcze widać tutaj zależność, że im więcej było dzieci, tym większe było natężenie hałasu. Kolejny wykres przedstawia poziom dźwięku A w przedziale wiekowym między 3. a 4. rokiem życia. Wzięto pod uwagę tutaj wszystkie sytuacje adekwatne do danej grupy wiekowej i obliczone dla każdego przedszkola i poziom dźwięku A według skali Thomsona był tutaj średni. I ostatni już wykres przedstawia poziom dźwięku A w trakcie zajęć w grupie wiekowej między 5. a 6. rokiem życia. Zostały tutaj wzięte pod uwagę wszystkie sytuacje adekwatne dla danej grupy wiekowej, została obliczona z nich średnia. No i według skali Thomsona poziom dźwięku A był tutaj na poziomie średnim. Przechodząc do wniosków, średni poziom dźwięku A obliczony na podstawie pomiarów ze wszystkich przedszkoli przekroczył 71,9 dB, a największy poziom dźwięku A, który został zmierzony, wynosi 93 dB i był zmierzony właśnie w trakcie zajęć wychowania fizycznego. Jeszcze jeden. I jeżeli chodzi o takie ogólne podsumowanie, środowisko akustyczne w przedszkolach Jest głośne, co nie oddziałuje pozytywnie na słuch dzieci. Hałas przedszkolny w głównej mierze zależy od rodzaju aktywności, którą dzieci wykonywały oraz konsekwencje zdrowotne wpływają zarówno na dzieci, jak i nauczycieli. Dziękuję.
Dobrze, w takim razie jakie pan by miał rekomendacje, no bo trudno trochę o ciszę w przedszkolu, prawda? Co zrobić?
I tak zastanawialiśmy się nad tym faktem. No przede wszystkim wyszło, że to jest 484 dzieci, które znajdują się w 24 grupach, także to wychodzi średnio 20 dzieci na klasę. Więc jednym z takich czynników, jakim by można było zrobić, to przede wszystkim zmniejszyć liczebność tych grup i po prostu tworzyć ich więcej na danym przedszkolu, no ale także zastanawialiśmy się nad tym pod tym kontekstem, że są te zajęcia dowolne, kiedy te dzieci mogą robić tak naprawdę to, co chcą, ale nie ma na te zajęcia tak jakby jakiegoś konkretnego pomysłu, jakiejś konkretnej zabawy, gdzie by te dzieci tą energię mogły wykorzystać, bo niektóre na przykład faktycznie były aktywne, gdzie się tam bawiły, krzyczały, tańczyły, śpiewały, a były takie, które siedziały i nie robiły nic, więc potem występuje tak jakby swego rodzaju taka zamiana, że te dzieci, które miały tą energię, to mają odpoczynek, a te, które odpoczywały, no to tej energii znowu mają dużo i znowu jest ten hałas, więc jakby wymyślić swego rodzaju jakieś zajęcia, gdzie porówno dzieci by mogły być wszystkie zaangażowane w tą zabawę, a nie byłby to tylko WF i takie rekordowe, że tak powiem, poziomy tego hałasu, no to też by to było jakieś wyjście.
Mam jeszcze tylko pytanie, czy mierzyliście Państwo też, bo to coś było bardzo nie tak z tym środkowym przedszkolem. Czy mierzyliście i w tej ankiecie takiej patrzyliście również na to otoczenie, bo być może to ono też powodowało, że tego hałasu było dużo więcej.
Niestety problematyczne było, że jak robiliśmy badanie w zeszłym roku, mogliśmy uwzględnić to środowisko zewnętrzne i przymierzyliśmy poziom hałasu przy otwartych i zamkniętych oknach, a z racji, że teraz robiliśmy to badanie w takim okresie jesiennym i pogoda nie sprzyjała, to nie mogliśmy tych okien otwierać ze względu też na to, że dzieci by mogły się po prostu rozchorować. Także w tym badaniu nie wzięliśmy pod uwagę tego środowiska zewnętrznego. Skupiliśmy się tylko na hałasie wewnętrznym.
Tak, obiektywnie, ale tak ankietowo nawet nie macie Państwo takiej wiedzy, jak one były ulokowane, bo fajnie, że jest uśrednienie i jest ten wspólny mianownik, że okna były zamknięte i ten pomiar był taki sam, ale właśnie czy to otoczenie mimo tych zamkniętych drzwi nie rzutowało na to, że to tak było. I bardzo zaskakujące jest i nasuwa się pytanie, co się stało z tymi 5-6-latkami w tym ostatnim slajdzie, kiedy to przedszkole takie dotąd ciche, nagle zupełnie inne wyniki są i rzeczywiście ta grupa jest tak głośna.
No bo tutaj zostały wzięte pod uwagę komplet wszystkich zajęć. Była wyliczona i z tych zajęć dowolnych, i z posiłków, i z WF-u. A tutaj było problematyczne to, że nie mieliśmy tak jakby możliwości dokonania ponownych pomiarów i akurat gdy wykonywaliśmy te pomiary na sali gimnastycznej, one obejmowały tylko grupę 5-6-latków, więc nie mieliśmy w grupie 3 i 4-latków takiej możliwości, żeby zestawić ze sobą te dane. Stąd może być to taka różnica.
Chodzi, że musimy te dzieci karmić po prostu, wtedy są cicho.
Bardzo dziękujemy za to wystąpienie, jak i wszystkie inne. Tym samym dotarliśmy do końca. Wszystkie wystąpienia zostały już nam zaprezentowane. Jednocześnie jako koordynatorzy sesji chcielibyśmy zarówno przeprosić za usterki techniczne leżące, co prawda nie po naszej stronie. Mamy nadzieję, że za bardzo nie zakłóciły przebiegu tej sesji i jednocześnie wszystkim uczestnikom chcielibyśmy serdecznie pogratulować wystąpienia w tej sesji zdrowia publicznego i ochrony zdrowia. Wszystkie wystąpienia były bardzo ciekawe. Jeżeli chodzi o ogłoszenie wyników, też serdecznie zapraszamy. Jutro od godziny 16:15 w auli A3 tutaj w Katowicach, Ligocie będzie oficjalna ceremonia zakończenia tej konferencji i wtedy również zostaną ogłoszeni laureaci prac z poszczególnych sesji. Na zakończenie jeszcze poproszę przewodniczącą jury o kilka słów. Panią doktor, jeżeli zechce, to również bardzo proszę o parę słów podsumowujących.
Proszę Państwa, więc bardzo ciężko mi, szczerze mówiąc, było oceniać te prace, bo są tak zróżnicowane i tematycznie, i metodycznie, że wolałabym w ogóle nie oceniać tego i gratuluję Państwu wszystkim serdecznie. Jestem pod wrażeniem tego, jak Państwo przedstawiali to, zwłaszcza w języku angielskim, z jaką swobodą Państwo się wypowiadają. No i gratuluję i życzę sukcesów w pracy naukowej w przyszłości.
Ja już w zasadzie trudno powiedzieć coś więcej. Też gratuluję Państwu bardzo i tak naprawdę no, stworzyliście szereg już rekomendacji tylko i wyłącznie już do wdrożenia, do działania. Także działajcie, proszę.
Dziękujemy za to podsumowanie naszym członkiniom jury. Dotarliśmy do końca naszej sesji. Ja dołączam się do tych słów i jednocześnie mam nadzieję, że będziecie Państwo aktywnie uczestniczyć w kolejnych konferencjach naukowych, w tym naszej uczelni, ale także życzę sukcesów na innych płaszczyznach związanych z rozwojem naukowym. No i mam nadzieję do zobaczenia. Dziękujemy serdecznie.
Oczywiście bardzo gratulujemy. Może taka sugestia właśnie tutaj ze strony pani doktor przyszłej o taką właśnie bardzo kobiecą sesję w przyszłości.
No rozważymy. Dziękujemy za tę uwagę.